Hello everyone, good afternoon. Welcome to today's Complex Pediatrics Echo Clinic. So glad you could join us. We'll start off with introductions for the day of our hub team members and then all of you, our spoke sites joining us today. So hi, back here in the corner running the computer and everything today, Troy Jorgensen, Program Manager for Project Echo Nevada.
Hi, I'm Sneha Sharma. I'm the admin assistant for Project Echo in Nevada.
Hello, my name is Ana Maria Mann. I'm a pediatric endocrinologist at Renown in Reno.
And I'm Yolanda Ortega Gamble, and I'm a registered dietitian and certified diabetes educator who works in Peds Endo with Dr.Manea.
All right, Dr. Eckert, please go ahead.
Hi, I'm Kathy Eckert. I'm a pediatric endocrinologist and director of the Complex Pediatric Project Echo.
And Dr. Lansing.
I'm Dr. Lansing. I'm a pediatric psychologist and professor at the university, and I'm our psychologist in residence on the Complex Pediatrics Project Echo.
And last is Alan, our IT support in Elko. Just a second, Alan, can't hear you.
How about now?
Yep, go ahead.
Alan Fisk, I'm in Elko. I'm a technical support for roundabout the state. If you need some help, let Troy know or myself. Thank you.
Not in Elko today, Alan. Looks like you're in San Francisco Bay.
Yeah, I could change that too.
All right, so we'll go out to all of you who've joined us for the session today. And if you do have a video camera, we want to encourage you to turn that on. So there will be a button in the lower left corner of the Zoom window right next to that mute button that says Start Video. So we'd love to be able to see you, help us interact with you just a little bit better. So R. Rauber is the first person. Please go ahead. I've unmuted you. We should be able to hear you. Okay, maybe you don't have a microphone on your computer there. So for those of you who, don't have a microphone, seems like we aren't able to hear you, please write in through the chat box letting us know who you are. I'll send something out through the chat right now so you can see that. It'll pop up as a little orange icon at the bottom of the Zoom toolbar. So please just let us know. Okay, Rachel Rauber, MS3. Thanks, Rachel. Next is Anna and a big group of, looks like third-year medical students. Please all introduce yourselves.
Hi, Anna and
Will, Andras, Heinrich.
Great, good to have you all with us today. Thank you. Next, we'll go to Anita Sabel. Anita wrote in MS3. Thanks, Anita. William Nawa also wrote in MS3. Thanks, William. Next, we'll go to Jen Tyndall. Jen, looks like you're joined by telephone, so *6 will unmute you, Jen, and we'll be able to hear you for introductions. Jen, if you just click *6 on your telephone, we'll be able to hear you to introduce yourself, please.
Can you hear me?
Yep, there you go, Jen.
Oh, good, yay. I'm a little technology challenged this Friday, I'm sorry. My name's Jen Tyndall. I'm the chief nurse of Douglas County School District down in Gardnerville and Minden.
Wonderful, good to have you joining us today, Jen.
Thank you.
Next is Dr. David Bayen. Dr. Bayen, are you there? Dr. Bayen, looks like you're unmuted, but we don't have audio for you. Oh, there we go.
Oh, there you go. Okay. I'm Dr. Bayen. I'm an internal medicine doctor, learning a little bit about kids.
Thanks, Dr. Bayen. Always a pleasure to have you. We had Nico Bufalino, MS3, right in. Thanks, Nico. Good to have you today. Claire, please go ahead. Claire Kwong, are you there? Could you introduce yourself for us, please, or write in through the chat box? Oh, thank you. Yeah, Claire Kwong, MS3. Sorry, I missed that. Then we have Annie Andriazzi, Elko, Nevada, school nurse. Great to have you today, Annie. Pretty Tony is the screen name. Could you introduce yourself for us, please? I've unmuted you. We should be able to hear you. Okay, maybe no audio there, so if you'd like to write in through the chat box to let us know who you are, that'd be great. And last is Skylar. Skylar, are you there? Could you introduce yourself for us, please? Okay, maybe no audio there either. So for those of you, yeah, we weren't able to hear you for introductions, please just write in through that chat box to let us know who you are for our attendance records and that sort of thing. Jen, if you wouldn't mind hitting *6 on your phone again, or whatever mute button you've got there. We've got some background noise there. Thank you. So again, I just want to welcome everybody to today's Complex Pediatrics Echo Clinic. So great to have so many new people joining us today. If you're not familiar with Echo, I just want to give a quick background on it. So what we do is we put together teams of specialists, as you see here at the table today, as well as virtually with Dr. Eckert and Dr. Lansing. And what we want to do is we want to help you with any challenging patients that you have, especially you who are school nurses, any of your students. And if you have questions about it, want to run it by a specialist that we have here, please feel free to do that. So that's what we'll do now, is we'll open it up to see if anybody has a patient that they have a question about, any concerns, that sort of thing. So feel free to unmute yourselves with the little microphone icon in the lower left corner of the Zoom window, or *6 if you're joined by telephone. So any cases out there that we can help you with today? All right, I think we'll get going with the talk for today. During the talk, feel free to unmute yourselves, again with that little microphone icon on the Zoom toolbar, or write in through the chat box if you have questions or comments. So this first slide is just letting you know that we do record all of these sessions. So if you have a problem with being on video, let us know. We can edit you out, that sort of thing. The next is, if you do present a patient case, just remember to not disclose any protected health information since we're in a group setting. And I'll turn it over to Dr. Manea.
Okay, hi again. I'm going to talk to you a little bit today about diabetes in children. This could be a very lengthy discussion, so we could have probably a 3-hour-long talk. Okay, so basically today I want to revise how diabetes mellitus presents in children, and going a little bit over type 1 and type 2 diabetes, what we typically see on physical exam, what type of labs do we do, how do we make the diagnosis, and how do we manage these children. So diabetes in children can come in various types for various reasons, but the most common by far is type 1 diabetes, and is caused by failure of the beta cells in the pancreas to produce insulin. Type 2, unfortunately, we see type 2 quite a bit these days. It comes in the context of obesity, and then you develop insulin resistance. And as the insulin resistance gets worse, the beta cells are trying really hard to compensate for that degree of insulin resistance, but at some point they start to fail. And then basically the child develops insulin deficiency and type 2 diabetes. Then there are these rare genetic defects that end up with MODY, maturity onset diabetes of the youth. We can have mitochondrial causes for diabetes, sometimes drug-induced diabetes, these children who receive supraphysiologic doses of steroids, children who have leukemias and cancers, they receive L-asparaginase, and this can cause insulinopenia, newer antipsychotics. Then we get many times consulted on patients who have CF, cystic fibrosis, and diabetes can occur in some genetic syndromes. So what is the definition of diabetes? Based on the labs we do. Normal fasting glucose should be less than 100. We have a time frame in between normal and diabetes. It's called impaired glucose tolerance, when fasting blood glucose is between 100 and 126. And then in diabetes, fasting is above 126, random sugar above 200, 2-hour postprandial above 200, and a hemoglobin A1C 6.5 and above. Definitely in a child who's asymptomatic and you find a level that could suggest diabetes, you want to repeat those results. You don't want to diagnose diabetes on a single abnormal lab as far as the child is asymptomatic. Now, in type 1 diabetes, what's the cause of type 1 diabetes? Autoimmune destruction of pancreatic beta cells. And there is, after this destruction happens, there is an insulin deficiency. So deficient, and then because of the insulin deficiency, glucose cannot be utilized as it should. Glucose is our main fuel, and in the context of a low insulin or no insulin in the background, cells will go to plan B fuel, which are fats. So fats are going to be catabolized, and the end product are ketones. And then you develop hyperglycemia in the context of not enough insulin in the background. Then this hyperglycemia, when it gets high enough, typically at a level of 180 and above, the kidneys cannot hold on those sugars, and then you start urinating glucose. Glucose is a large molecule, attracts a lot of water. You are urinating a lot together with glucose going out in the urine. You become dehydrated, so you drink a lot. Plus, you are going to lose your main fuel, which is sugar, and then you are going to lose weight and be hungry all the time. So it's a vicious circle that goes on and on and on. Type 1 diabetes doesn't develop overnight. We learn these days that type 1 diabetes might start months and years before the clinical diagnosis is made. So here I'm trying to use this point.
Yep.
Can I use this?
Yeah.
Oh, yeah. So this is the first phase when these children will have a genetic predisposition for type 1 diabetes. But at this point, here, at this stage, their beta cells are still working very well, 100%. Nobody knows that these children, and we don't know at this stage whether you are going to develop or not type 1 diabetes, but you have definitely a genetic predisposition. Then stage 1 comes here when you have the genetic predisposition and now you start developing autoantibodies and the destruction of the beta cells start to happen. But typically sugars are normal in this stage and you are not symptomatic. Then in stage 2, there's still autoimmunity ongoing, genetic predisposition is there, sugars start to be abnormal, no symptoms, but as you can see here on the graph, the beta cells are decreasing in number. And then by stage 3, the symptoms are there, sugars are very high, and maybe you are left with 20% of cells that are still functioning. So when we think about the epidemiology of type 1 diabetes, again, type 1 diabetes is the most common cause of diabetes in children. 80% of all diabetes, 9 years old and younger. And then incidence is increasing, 1 to 2 per 10,000 per year. And peak incidence is in early adolescence. It's more common in Caucasian and less common in Asian and African American. So new onset type 1 diabetes, keep in mind 30% will present in DKA. And this is important to keep in mind because sometimes these children who present in diabetes ketoacidosis will be very, very sick. And if we look here down at the age distribution, so between 0 and 4 years of age, presentation in DKA is 37.5%, versus in older children is only 14.7%. It kind of makes sense, these numbers make sense to me because I have seen these young children coming in particularly sick. And why this might happen is because when a child comes, 15-month-old comes in with vomiting, people are not necessarily thinking that this is type 1 diabetes, new onset, and DKA. You might think that this is just a gastroenteritis. So many of these young children end up with a diagnosis pretty late, and they end up with a hemoglobin A1C significantly elevated. For genetic susceptibility, monozygotic twins will have a 40% risk of developing type 1 diabetes. This is an interesting number considering that we are talking here about identical people, in theory, monozygotic twins, and it's just 40%. So definitely there must be something in the background, something else in the background which will trigger the type 1 diabetes onset. While in siblings, the risk is around 5%. What is the trigger? What is that trigger that will cause type 1 diabetes onset, clinical onset? We have a genetic susceptibility, but what will trigger the development of the antibodies at the downhill progression of type 1 diabetes? We don't exactly know. It could be an infectious trigger. Incidence, it seems to be more common in fall and winter when we start to get more and more viruses and infections, upper respiratory, all sorts of gastroenteritis type of infections. Could it be something else? Cow's milk, toxins, something in the environment? We don't know exactly. So how do we take care of diabetes? Once we make the diagnosis of diabetes and we have a child with a diagnosis of diabetes, type 1 diabetes, we start checking sugars. We typically recommend checking sugars before breakfast, lunch, dinner, and bedtime. In the middle of the night, that can be midnight and 4 a.m. or just 2 a.m. The nighttime sugar check might go away once the child is well into this diagnosis. Anyway, these days we have fancy technology. We have continuous glucose monitors, and you're going to hear more about this, I think, next week. So that type, the continuous glucose monitor takes away the stress of checking blood sugars and the stress of hypoglycemia in the middle of the night. And here is a picture with a couple of the tools that we use, insulin pump and a glucometer, and then how we deliver insulin with a pen, and we can use syringes less often these days. All of my patients, I think, are on pens. And there is so much more technology coming out. And what type of insulins do we use? So we have to have a fast-acting insulin and a long-acting insulin. Fast-acting insulin, that can be Humalog, Novolog, Epidra. This is given ideally just before the child starts eating. So before breakfast and before lunch and before dinner. The child is going to get the sugar, and then if the child is older and is able to approximate how much he or she is going to have, counting the carbs, and then covering those carbs with insulin, doing the math, and then coming up to an insulin dose, and then that's how much this child is going to get before the meal starts. That's the ideal situation. And the reason why we want this to happen is because Humalog, Novolog, and Epidra, all of these fast-acting insulins, kick in within the first 5 minutes of administration. So you have that insulin in your system by the time you start eating. And there is a peak at around 1.5 hours, and the duration of action is around 3 hours. Sometimes there could be a tail up to 5 hours. And then another long-acting insulin that we like to use is Lantus. These days there's another one, Basaglar. We have the other one, Trugeo. These are the main ones that we use. And all of these will have typically 24-hour duration of action, no peak, and it kind of creates that nice baseline insulin level in the background in a 24-hour period. There is NPH and Levemir. Sometimes some insurances will cover Levemir. Levemir typically is better if it's given twice a day, so every 12 hours. NPH, I never use NPH these days for my diabetes patients. I used it in the past for my cystic fibrosis diabetes cases. Okay, and this is another explanation of how this long-acting and fast-acting insulins are working. So you get breakfast, lunch, dinner, you get this fast-acting insulin that comes in and helps you to go over the hyperglycemia that comes in with every meal, every main meal. And then in the background is this nice Lantus or Basaglar or whatever you are using that helps you in this 24-hour period. When you get insulin, you are at risk of hypoglycemia. This comes along, unfortunately. And once you have a diagnosis of type 1 diabetes, sugars might be high, low, within target. And we always want to make sure that parents and caregivers and children are well educated on hypoglycemia, because hypoglycemia can easily kill you. And if hypoglycemia happens on and on and on, children will not experience hypoglycemic symptoms anymore, and that's scary. That's called hypoglycemia unawareness. And that can, again, kill a child. So every child, I always like to ask with every visit, how do you feel when you go low? Because symptoms might change as time goes by. And I also want to identify hypoglycemia unawareness, especially if I see many low sugars on the downloading clinic. And children might tell you, I feel shaky, weak, dizzy, I have cold sweats. If the child is a toddler, parents will tell you he or she's just throwing a fit, temper tantrums. If it happens at night, that's the most scary situation, especially if you don't have a Dexcom, a continuous glucose monitor to notify you that you drop low. And you could have nightmares or you can sleep in an agitated fashion, but many times these children will not know that they have a low sugar in the middle of the night. And how do we treat these low sugars? We treat with simple carbs. You don't want to do cookies or you don't want to eat something. You want to drink juice, eat candies, eat sugar, take honey if you are above 12 months of age, gel for decorating cakes, so simple, straightforward carbs. And you want to do it, there's a particular rule, and Yolanda will tell you about how many carbs you need based on how old you are. But that's the bottom line. You want to use simple carbs, and then you repeat your sugar in 15 minutes, the 15 rule, and you have to do this on and on and on until your sugars are above 70 or 80 or 100 if you are a baby. And then you want to make sure that the hypoglycemia has resolved.
So I can talk a little bit more about that. I was thinking though, when Dr. Manea was talking about during the visit, I'll often ask the other family members how they can tell if the person has a high blood sugar or low blood sugar, because they often have a very clear idea. So parents will say, like, they see dark circles under the child's eyes, or they can see their temperament change pretty quickly. And I was sitting with a 16-year-old yesterday for a couple of hours. We were doing education, and there was this moment when she switched very quickly. She got like pretty impatient. I was trying to teach her how to download an app for her CGM, and it was really quick. And then she said maybe 5 minutes later, and I was kicking myself for not asking her to check right then, but she said, I need to check my blood sugar, and she was 66. And I don't know her very well, but in the future, I think I would be able to identify like this very sharp sort of change in her personality. So not only the patient's understanding, like telling you what they feel like or at what number they start to feel low, but then I think asking, I'm sure you do too, ask the other family members what they notice, and having a little bit of a conversation around that. So talking a little bit more about the basal insulin or your long-acting insulin, typically lasts 24 hours in the body. So Lantus we're usually giving once a day. It's important to give it at the same time every day. It can be given independent of food. So sometimes families will choose to give it with dinner because dinner is at a stable time and that's the best time to do it. Lots of times they'll do it before bed. So it just sort of depends on when is a good time for them. And we might decide nighttime or morning depending on the age of the child, and as well. Younger kids, it seems like we'll do it earlier in the day, in the morning more often, so that it's not in full effect during the night. Usually your basal insulin is about 50% of your total daily dose, so we try to balance those as well when we're making adjustments to insulin. Given with or without food, and it's the same dose every day. So when you're looking at your bolus insulin, your fast-acting insulin, you're adjusting depending on what you're eating and what your blood sugar is. That's different with your basal insulin. You're going to be giving the same amount every day until we decide to make a change to that dose. Your bolus insulin is used to cover the carb that you're eating in food, and we usually use an insulin to carb ratio, which requires some math. So they'll need to count carbs, be able to calculate the carbs, calculate them accurately. For a teenager who's going to lunch with their friends, that means that they're figuring out how much carb is in whatever they're going to eat at KFC, doing the math correctly. And you hope that they're doing that. Most of the time, well, whatever. They often just give an estimate and a guess, or they say that food looks like about 6 units. And then I'm happy that they gave any insulin at all, so yay. Correction doses are used at meals also. So there's lots of reasons, right, that a blood sugar can be high besides the food that you're eating. So the insulin to carb ratio is covering the food that you're going to consume. But before meals, we'll also ask that they check their blood sugar and then give a little bit of extra insulin to make up for them being high. So there's usually doing 2 things. They have to be able to calculate what their correction, how much they need in a correction, how much they need to cover their carb, and then actually give that much. So there's lots of things that can happen in between there. Challenges for families. We definitely have families who are not, who can't do the math. I mean, I've had to show families how to use a calculator before. Lots of times reading labels. Is there 1 serving? Are they, eating 2 slices of bread or 4 slices of bread? Are they, figuring that all out? So that can be really difficult for families. And then just the challenges the other challenges they have going on. If a family member, yesterday, mom has a family member in the hospital, in the ICU, the kid doesn't like to count carbs or doesn't. There's all of these sort of other factors that put into play whether or not they do what they're going to do, which I'm sure Dr. Lansing, she's got all of the answers for all of those things. But so those are some of the challenges that we deal with every day, and I'm sure the school nurses that are on are dealing with those obviously as well. Did they remember to bring their insulin? Did they actually stop by the office to check? Do they have labels on the food? Once in a while, if it's too difficult for families to do the math, then we try to do set doses. This one yours or mine? This one's mine. So hypoglycemia. So if it's severe, so I wanted to make sure we talk about altered level of consciousness, giving glucagon, IM, or now we have Baqsimi, which is a nasal glucagon. So it's 3 milligrams. And, in the past, we've only had glucagon shots that go in the leg. If someone is having a seizure or altered mental status, you'd have to give glucagon, but now we have Baqsimi, which is kind of cool. So it goes in the nose and may or may not be easier to give depending on the situation, the circumstances.
So definitely here, a little bit a point here. So you want to do oral treatment with simple sugars, again, table sugar, honey, juice, candies. If the child is awake, alert, capable of taking anything by mouth, if the child is kind of not awake and alert, not looking well, definitely if there is loss of consciousness, you want to use glucagon. And then if the child needs glucagon, you need to do it now. You don't call 911, you don't do anything else. You just do glucagon. And then you call 911 because this is going to save this kid's life. After you do glucagon, you place the child on the left side, so because the glucagon will spike the sugars pretty quickly, and then you can have vomiting, and then the child might might get this gastric content in the lungs. So you don't want that to happen. So always keep in mind, as long as the child is awake and alert, you do oral treatment for hypoglycemia.
So there was a question that came in. Can you talk about how much diet education is given to children who are newly diagnosed?
Yes. So, you want to?
Sure. So usually when somebody is diagnosed, within the first week, and usually the first 3 to 5 days, the dietitian and diabetes educator, so there's 2 of us in our office, 2 dietitians who are also diabetes educators, and we see them. We see them at every visit with Dr.Manea to answer, we hope to, I'll say that, to see them at every visit when they come in just for their routine visits, and then families are always invited to make additional appointments. It's not unusual for families to see the physician every 3 months and then to see me or Steve and our other dietitian in between appointments. And then they have contact with us just through my chart and phone calls. So it's not unusual for me to spend 45 minutes on a phone call going through blood sugars with the family over the last 4 days and trying to troubleshoot. What were they eating? When did you give it? Was the insulin given before? Was it given after? Are they going into scar tissue? Are they rotating their injection sites? We spend quite a bit of time. Yesterday I spent 2 hours with a family where the girl's been diagnosed for quite a while, but she brought her best friend in, and because her friend wants to learn more about diabetes, and then an hour with somebody else who's been diagnosed for quite a while. In the hospital, they get, I would say, probably 3 to 4 hours of education with the dietitian.
And it also depends. So all of these new onset diabetes patients that we diagnose here at Renown in Reno, we admit them, regardless if they are in DKA or not. There are in other states, in other cities, at other hospitals, they might do outpatient education. They might have that set up, but we admit these children. So, and one of the reasons for the admission is exactly the diabetes education, and they see the dietitian and they see the diabetes educator. So, and then of course that the admission can be longer or shorter depending on how knowledgeable and how how knowledgeable the parents are. Sometimes mom has type 1 diabetes and then she knows everything, or how much education this family needs. Some families will stay in the hospital sometimes for a week because they just don't understand diabetes care, basic diabetes care. So by the time they go home, they have a good baseline. They should have a good baseline to take care of the basics. And then we try to see them as early as possible in clinic. The diabetes educator is trying to see them as early as possible in clinic so they get more education. And then we identify gaps and we fill those gaps.
I also, depending on where they're at, I set up more visits. So when somebody's newly diagnosed, they are calling in blood sugars every single day. Friday, we try to get a plan for the weekend, but we're making adjustments and looking at their blood sugars every single day. That's our intention. Whether or not a family actually calls us and reports the blood sugar is a little bit of a different story. And then we go to, depending on where they're comfortable, we'll go to, okay, you can call in blood sugars once a week, or let's, go a little bit longer when they start to feel more comfortable, or we feel more comfortable. If they're every week, 4 months on end, sending us blood sugars, then we'll ask them to come in. So let's sit down and try to identify what's going on. You can.
Okay, and do you have any questions regarding this? No? Okay, and sick day management. This is a very important part of diabetes care. So what we teach families is whenever the child is sick with an upper respiratory infection, gastroenteritis, flu, anything that's unusual in that sense, they need to be checking ketones. So this is what we tell them. Regardless what your sugars are, if you are sick, you start checking for ketones. Typically in the urine, for younger children, we try to obtain a blood ketone meter because it's harder in an infant or a toddler to use these urine ketone strips. That's one situation. And then if they have moderate or large ketones, we teach them how to take care of these ketones. In order to clear the ketones, basically what you need in that type of situation, you need extra fast-acting insulin. There are various protocols, various ways of doing this, but that's the bottom line. You need more fast-acting insulin every 2 to 3 hours. And then there's another situation when you are at home, you don't necessarily have any particular symptom of a potential infection, and your sugars are running higher. I always tell my patients to take a step back, think about what happened that afternoon or that morning. Was the dose miscalculated? If they are on pumps, is the pump working? Does the pump look right? When was the site changed last time? And then kind of being critical and analytical about what has been going on in the last few hours. And if the sugar continues to be high in 2 or 3 hours, then they need to start checking for ketones. And if the ketones are moderate or large, they again need to start the same protocol in order to get more fast-acting insulin in the system. And they need to continue checking urine for ketones or blood for ketones until the ketones are at least small or negative. Or if they are sick and the infection is obvious, they need to continue checking these ketones throughout the time of illness. If they are on a pump and they have ketones, moderate or large, you always have to assume that the pump has a problem. So we tell them to change the site, do a site change, and then as long as they have moderate or large ketones, they keep the new site and the pump running the basal rate, and then we do injections with fast-acting insulin every 2 to 3 hours in order to clear these ketones. And during this whole time, it's very important to be well hydrated. So drinking water is very important. It's always tricky in toddlers and young children who have this problem, and especially if they start having vomiting, because that typically means a visit to the emergency department. We can help a lot over the phone, and we do this, as long as the child is not vomiting. Even in an older child, if vomiting happens, plus minus diarrhea, dehydration is a risk, and we get into a very vicious circle, and they need IV fluids by that time. Okay, so now going to surveillance. We see these patients in clinic, these patients with type 1 diabetes, and we need to, of course, discuss sugars and where they are and what they need and all the problems associated with type 1 diabetes. But we have to also keep in mind that these children on a long run, they are prone developing other conditions, other autoimmune conditions, and also diabetes-related complications. The good news with type 1 diabetes is that if they develop a diabetes-related complication, it takes some while for those to develop. So you don't, in the majority of them, you don't need to start the screening right away. That's different in type 2 diabetes. So for the nephropathy, we check a blood pressure every visit, and a diagnosis, of course. And then we start checking albumin to creatinine ratio 5 years after type 1 diabetes diagnosis, and then yearly after that. For the cardiovascular disease, we check lipids. At 10 years of age, we can check those earlier if there's a risk, there's a family history of dyslipidemia. But you have to keep in mind that lipids might be abnormal just in the context of a poorly controlled diabetes, or right after the diagnosis, the lipids might be abnormal because the child has been living with hyperglycemia for a while. And then you can repeat those every 3 to 5 years. Smoking, secondhand smoking should be addressed regularly. Eye exam, at 10 years of age or at the onset of puberty, and then every 1 to 2 years. Neuropathy, foot exam at diagnosis and every visit. And then the other autoimmune diseases. This is a very important aspect of care, because these children have a high risk of developing celiac disease, thyroid disease, primary adrenal insufficiency, or Addison's disease. So for the thyroid disease, we can check the thyroid function and plus minus antibodies around diagnosis or at diagnosis, and then every 1 to 2 years and with symptoms. And then for celiac disease, definitely a diagnosis, and then every 2 to 5 years or with symptoms. For Addison's disease, for adrenal insufficiency, if that happens, you might see a child with type 1 diabetes who now has ongoing hypoglycemia. And that could be a sign of adrenal insufficiency. So keep that in mind. And then lipohypertrophy. If you go in the same spot and you give yourself shots in the same spot because that's your favorite spot, and you don't rotate the sides, you will develop this dystrophic spots in your adipose tissue, and then insulin will not be absorbed. So at every visit, when I palpate these places where these children are giving themselves shots, I try to identify the lipohypertrophy. And definitely, if I identify those, I always recommend increasing the number of sites. That's very important. So for diabetes ketoacidosis, for DKA, what is the reason for DKA? I hear a lot of misconceptions. People are thinking, I don't know, I developed DKA because I'm sick, or who knows what. But basically, you develop DKA because there's not enough insulin in your body, or because you did not pay attention on the warning signs. That's why it's very important, if they don't know what they need to do for taking care of a flu. Let's say you have flu and now your sugars are high and you have ketones, you have to be proactive. You have to take care of those ketones right away. If you postpone doing so, the odds is that you are going to end up in DKA. So DKA, basically, you develop an insulin resistance. There's when you are sick, you develop insulin resistance. You need more insulin. And if that does not happen, you are going to end up sick with worsening hypoglycemia, ketones, which will make you even more sick. And then you will have vomiting, abdominal pain, you will have more urination, and if it's really severe, you'll have this typical Kussmaul breathing that's fast and low amplitude, and then altered mental status with potential brain damage. So by the time you develop diabetes ketoacidosis, there's severe dehydration, acidosis, electrolytes imbalances, and definitely you need admission. We admit our children to pediatric ICU and we place them NPO, so nothing by mouth. And we start with fluids, so bolus and then fluids, IV fluids at 1.5 maintenance rate, and insulin drip. Okay, questions about type 1 diabetes? No? Okay.
Nope.
Okay, then, so, I mean, we could talk about type 1 diabetes probably for many hours, but we need to move on now to type 2 diabetes. So, as I said at the beginning of this talk, it appears in children in the context of obesity. And it's insulin resistance, hyperglycemia, and then glucose toxicity to beta cells. So as obesity develops, there is insulin resistance, and initially glucose levels may be normal. The child is asymptomatic. And then you have the second stage where there's impaired glucose tolerance with this fasting glucose between 100 and 126, and OGTT 2-hour glucose between 140 and 200. And then at some point, there is a total decompensation, and you develop type 2 diabetes, and the labs will show type 2 diabetes with random glucose over 200, fasting above 126, and OGTT at 2-hour above 200. And type 2 diabetes can present with DKA. It's less often than in type 1 diabetes, but it is a possibility. Type 2 diabetes has been increasing in incidence, particularly in teenagers. Mean age of diagnosis is 13.5, and puberty is coming with a peak of insulin resistance. So having that plus having obesity with insulin resistance will increase this risk of type 2 diabetes in these teenagers. In comparison to type 1, which is more common in Caucasian, type 2 is more common in African Americans, Hispanic, and Native Americans. And it has a stronger polygenetic basis than type 1, almost 100% concordance in monozygotic twins, And more than 75% of cases in youth have a first or second degree relative with type 2 diabetes. So again, we already discussed about the numbers, how we diagnose type 2 diabetes. And how do we diagnose this type 2 diabetes in children? So sometimes it's an incidental finding. They ended up having some labs for various reasons, or as part of screening in the context of obesity or family history of type 2 diabetes, you find a particularly elevated glucose, or many times a high hemoglobin A1C. Or sometimes just getting a good history, you will hear symptoms of diabetes, like polydipsia, polyuria, or sometimes even worse, they will present in DKA. So on the physical exam, typically these children will be overweight or obese and will have acanthosis nigricans, which is this brownish skin discoloration that's more obvious on neck, knuckles, axillary areas, inguinal areas, plus minus they might have hypertension. If the child is not in DKA, and if the hemoglobin A1C is just mildly elevated in the diabetes range, definitely we want to promote lifestyle modification with improving, slowly improving the weight and BMI. We ask the dietitian to meet with the family. We advise for exercise, daily exercise, aerobic type of activities. And we start metformin. This is the main medication that we use, the first-line medication that we use in type 2 diabetes in children. Some of them will need insulin, depending on their presentation initially and depending on how their response to metformin is. We should be aggressive. The newest data shows that we should be aggressive and add insulin relatively early if metformin doesn't work. So for type 2 diabetes, we advise if they are not on insulin, we are not as strict with sugar checks, but still we want to see some sugars at least twice a day, morning and 1 to 2 hours after a meal. And then definitely if they feel symptoms of low sugars, they should check a glucose. So once you have insulin resistance or type 2 diabetes, you might be at risk of developing other problems: nephropathy, hypertension, dyslipidemia, PCOS, non-alcoholic fatty liver disease, systemic inflammation. And the problem is, once you have type 2 diabetes, many of these problems can be there at diagnosis.
So we're getting a little close to time.
Okay.
So if you want to just wrap up.
Okay, I'll go over. So metformin helps basically with better glucose utilization. And then side effects for metformin: abdominal pain, diarrhea, not feeling well in that sense, typically goes away after the therapy is started. We start on the lower dose and slowly go up. And then this is what I was trying to underline here, the fact that in type 2 diabetes, we start many of these screenings at diagnosis and then early. So also an important thing is that sometimes we get these new onset diabetes patients, and it's very hard to understand, is this type 1 or type 2? Because 15 to 25% of newly diagnosed type 1 diabetes patients may be obese. Many children with type 2 diabetes have ketonuria or DKA diagnosis. But even though sometimes we are like thinking, okay, is this type 1 or type 2? Many times it doesn't really matter in that point in time because you have to take care of them clinically. So you do insulin if you have to, and you can add metformin, and then later on we can check antibodies, and typically those are high in type 1 diabetes. We check anti-GAD, islet cell antibodies, and also we can guide ourselves whether this is type 1 or type 2 based on the clinical evolution. Type 1 diabetes patients will present with honeymoon when they are still able to produce some insulin in the background, so they might even be off insulin for a while after diagnosis, versus type 2 diabetes children will require more and more insulin because of the insulin resistance. So I have to be fast now at the end. So keep in mind, type 1 and type 2 diabetes both are increasing in incidence. And if the child has symptoms, and especially if the child has ketones, that child needs admission to the hospital and needs insulin. If obese or signs of insulin resistance, lifestyle modification is very important and should be one of the first lines, and then metformin, and then we need to monitor for comorbidities in both diagnoses.
All right. Thank you so much, Dr. Manea and Yolanda. So we are over time, so if you need to take off, please feel free to do so, but we do have them available for questions. So if you have a question, feel free to unmute yourself with the microphone icon on the Zoom toolbar or write in through the chat box.
I just have one comment that I always like to discuss with medical students particularly, but also primary care physicians who are at the forefront of seeing these kids who, as they were mentioning earlier, might present, especially with type 1, more with a kind of a stomach flu picture. And the magic question that we all have to ask, and there's truly only one, is in the face of vomiting, plus minus fever, plus minus diarrhea, what is your child's urine output? And if the urine output is still high, then you have to at least think about type 1 diabetes. Because typically, if you have a stomach flu or something like that, your urine output will be going down, okay? And so one of our goals, of course, is to minimize presentation with diabetic ketoacidosis, particularly in the little guys, because they get sick so quickly. So please just remember that. It's easy to ask, doesn't take much extra time. And I think a lot of times we forget about that very question.
I had a question kind of related to that.
Yeah, go ahead.
So if you have a patient that, as Dr. Eckert just mentioned, has normal urine output or even increased urine output, yet they're presenting with these GI symptoms, what tests do you want to order, like a preliminary test? So of course we know that ketonuria is a common finding, so perhaps ketones. Would you get blood gases to assess for metabolic dysfunction?
So you have a patient and you don't have a diagnosis of diabetes, right? But you suspect it, right?
Right.
Yes. So I'm not sure what you have in your clinic, but you can always do a CBG, like a point of care glucose. Or you can even send the child to the lab to have a plasma glucose, and that would give you an answer, or plus minus a hemoglobin A1C. If you have the capability of doing a point of care UA in clinic, that would also be helpful, because if this child truly has type 1 diabetes, you will see glucosuria, ketonuria, which would be a high indication that that this is type 1 diabetes, or diabetes, new onset diabetes.
Okay, thank you.
Yes.
Thanks for the question. Any other questions out there before we wrap up for today? All right, well, I want to thank you all for joining us today and let you know about our next upcoming session. So this was our first in our series on diabetes for our Complex Pediatrics Echo Clinic. So next up, Friday, February 14th at noon, we're going to be talking about diabetes nutrition and technologies, so pumps and glucose monitors. And then on Friday, March 13th, Dr. Lansing talking about mental health screening and brief behavioral intervention for pediatric diabetes. So we hope you'll join us at those future sessions. In the meantime, feel free to reach out to me. Again, Troy Jorgensen, Program Manager here at Echo Nevada, if you have any questions. And have a great weekend. Thanks, everybody.